My subspecialty is behavioral neurology, which primarily encompasses memory disorders. The most common memory disorder in the United States is Alzheimer's disease, but there are quite a few other disorders that can cause memory impairments, including things such as stroke, medications, etc. There are a couple of really huge misconceptions about memory disorders, and unfortunately these misconceptions are often promulgated by physicians as well as lay people. The first is that there's nothing that can be done for somebody who has a memory impairment. Well, you can do something for almost everyone with a memory impairment. Now, as far as medications for patients with memory impairment, you can probably help close to 40 to 50% of patients, whereas back when I started practice in 1984, we had no medications to help patients, so we were able to help 0%. So it's a big improvement over the years. The second misconception is that patients with memory disorders, or I don't know how to put it other than to say that some people consider them less than equal human beings. And that's unfortunate. Dementia is not a disease. Dementia is a clinical condition. Basically, when you say someone has dementia, you're saying they've had a deterioration in their cognitive function below the normal level to the point where they can't perform certain activities. Now, what those activities are depend on which criteria you use to diagnose dementia, and there are different diagnostic criteria out there. There's also an intermediate state between normal and dementia. It's called mild cognitive impairment. And this is someone that really is not functioning up to normal in one particular cognitive sphere or more, but is still functioning pretty well because they're making adaptations. Maybe they're taking a lot of notes, relying on other people, relying on certain systems to get them by. So those are the clinical states: normal, mild cognitive impairment, dementia. Now, when you look at dementia specifically, the most common cause in the United States is Alzheimer's disease, approximately 65%. Another 20% are probably what's called Lewy body dementia or Parkinson's disease dementia. A lot of people are unaware that patients with Parkinson's disease can have cognitive impairments. 50% of patients with Parkinson's eventually develop some cognitive impairment. There's another condition called frontotemporal dementia, which is a smaller percentage, and then quite a few other types of things that can cause dementia. Another thing that's a misconception about dementia is that it's irreversible. Remember, dementia is a clinical state, and that clinical state depends on the cause, and some of those causes are treatable and reversible. It's a small percentage, but it's important to remember that. Alzheimer's is not reversible. It's an irreversible cause of dementia, but some dementias are actually reversible or treatable. Well, as I said earlier, basically all are treatable. We'll start with Alzheimer's. 90% of patients with Alzheimer's start off with what's called short-term memory impairment. And this primarily is manifested by people having difficulty maybe remembering the date or the day of the week. Now, everybody does that at times. Also, repetition of questions or statements. Not the day later or 2 days later, but if somebody asks you 3 times on a car ride, where are we going within 20 minutes, that's one of the early signs, these type of things. Patients also might have geographic disorientation, get lost driving in familiar areas. They may forget steps in cooking, things they used to know how to do as far as cooking, or maybe in operating a computer. They can't remember the steps that they used to know. It's important to differentiate that from somebody who never really used a computer, was never facile, or was never a cook. So remember, it's dementia, DE, meaning a decrease in mentation, and that's what you're looking for, a change in someone's cognitive abilities. And the person that can usually tell you that best is someone that knows them best, which is usually spouse or daughter, son. The first thing I do is I introduce myself to the patient and the family members. I then basically ask the patient why they're there to see me. This is very important to see if the patient has insight into their problem. Oftentimes the spouse or caregiver will try to jump in because they know the patient may not be able to relay that information, but I want to understand how much the patient understands about their problem. Oftentimes they don't have a problem. I have had many patients brought to me by family members who thought they had a memory problem, and it was just typical of what's called age-associated memory impairment. The majority of people do have the loss of memory and cognitive function as they get older. So that's my job, to try to differentiate what's normal, what's not normal, what can be treated, and how do we treat it. History taken is very important, not only from the patient, as I said, but from the person that is accompanying the patient. And after that, perform a full neurological examination, including a detailed mental status evaluation, to try to get a concept of what that particular individual's neurocognitive profile is. Specifically meaning, what aspect of that cognitive function might they be having trouble with? Is it short-term memory? Like, as I said, 90% of Alzheimer's patients begin with. Is it a language function? Is it a attention problem? Is it a visual construction problem? Is it a difficulty with the insight or poor judgment? Because the different neurological conditions often present with different patterns of cognitive impairment in different time courses. So it's very crucial to get an adequate evaluation. Now, many of the patients that come in are a little fearful of coming to see me, as one might expect. If someone's questioning your mentation, you get a little defensive, especially I have a lot of high-functioning people that come in and all of a sudden they're not able to do what they could do in the past, and it scares them. So you have to set the patient at ease, and I try to do that with as much humor as possible. I'm not a comedian, but it is essential to try to make the patient feel comfortable, because if the patient is anxious, it's going to adversely affect their performance in the cognitive testing that I'm doing. Once they are diagnosed with the cognitive problem, I then look at it and see what sort of testing that might be necessary to rule out specific conditions. Patients, for the most part, their caregivers are not familiar with this problem. Some are, they've had other family members. So you have to educate them. You have to explain to them often the behaviors of the patient. It's easy to get irritated if someone keeps asking the same question. I've had one daughter told me her mother asked her the same question 100 times in a day. And it requires a lot of patience on the caregiver's part and understanding. And the more they understand about why the patient's doing certain things and they're not doing it deliberately to be obstinate or obstructive or to aggravate someone, then they can better deal with the patient. And the patient obviously will react better to it. The patients do not react well to conflict because oftentimes, due to their cognitive impairment, they don't understand what the conflict is about, and it gets the patient frightened. And when you're frightened, just like if you're anxious, your cognitive function decreases.